Hi, my name is Mervyn Singer. I'm Professor of Intensive Care at University College London in the UK. And what I'd like to talk to you today about is cytokine storm in COVID-19. Is it actually a storm or is it more of a gentle breeze? This is my little simplified table comparing COVID-19 sepsis against standard sepsis, which is usually bacterial. I think there's a much bigger immune system activation in standard sepsis, a bigger cytokine response. So that's where there's more of a storm, more endothelial activation. But I think in COVID-19, there's more of an acute phase inflammatory response and certainly much more thrombosis. I don't think coagulopathy is a big problem with COVID-19, but multi-organ failure is much more commonly seen with a standard septic insult. However, this notion of a cytokine storm has become popularized both in the mass media and in the medical literature. So these are just a few examples where they highlight cytokine storm COVID-19, the anger of inflammation. And that's encouraged lots of academic groups, lots of companies to throw lots and lots of immunomodulatory drugs at patients with COVID-19, either as compassionate use or as part of phase 2 or phase 3 trials. Here I'm just showing a recent journal article in Nature Biotechnology looking at different drugs used to block anti-interleukin or block drugs used to block interleukin 6, interleukin 1, GM-CSF, or tumor necrosis factor. As you can see, just for these four alone, many studies going on. And the popular ones have been anakinra to block interleukin 1 and tocilizumab to block interleukin 6. And there was a huge amount of compassionate use that's been generated with these drugs. However, is it necessarily appropriate? And I think people are now beginning to question, does COVID-19 actually induce a cytokine storm? This paper's come out from Pratik Sinha, Michael Matte, and Carolyn Calfee in San Francisco, and they compared 5 studies of COVID-19 measuring plasma interleukin 6 with 3 studies that they'd been involved in ARDS, multi-center studies. If you look at the top right panel, in COVID-19 severe disease, the interleukin 6 levels were a bit higher than normal, but not hugely higher. If you compare this against their ARDS, hypo and hyperinflammatory phenotypes, in fact, personally, I think hypo is a misnomer. These patients are inflamed, but not as much as the hyperinflammatory group. But you can see there's 1 to 2 log order difference in interleukin 6 levels. So standard ARDS is much more inflammatory in terms of IL-6 levels compared to COVID-19. This is one of the early papers that came out of China, was published in The Lancet, and in the supplement they show these graphs of loads and loads of different cytokines. And you can see that compared to healthy controls, there was an increase, but the levels weren't particularly large. And this is just a smattering of TNF alpha, interleukin 1 beta, interleukin 10, interleukin 6, GM-CSF, etc., etc. So if you look, for example, at interleukin 6, very little difference compared to healthy controls, yet people are looking at giving anti-IL-6 therapy. The same for interleukin 1 with anakinra. Again, the levels aren't particularly large. GM-CSF, people are both looking to give GM-CSF and also block GM-CSF, so completely contrary views. But again, the levels are not much different from healthy controls. Just to make the example, this is a study, the leopard study I was involved with. The main paper came out in the New England Journal. This one is a post hoc analysis of blood samples collected, and here showing interleukin 6, interleukin 8, interleukin 10. And these are patients with septic shock. And putting these side by the Chinese data I showed you in the Lancet, you can see that, I'll just show here, interleukin 6, this is on logarithmic scales, was way higher, about 600 compared to about 20 in the COVID Chinese patients. Interleukin 8, about 200, as opposed to about 20. Interleukin 10, you're looking at values of around 80 compared to less than 10 in the COVID-19 patient. So there's at least one log order difference between generally a bacterial septic shock population and COVID-19. This nice compilation came from Guillaume Monneret and colleagues in the Journal of Medical Virology. And they looked at the literature, and on the right, you'll see all the different studies they culled to get the data from. And they looked at interleukin 6 in COVID-19 patients, septic shock, and cytokine release syndrome, which you see as part of CAR T therapy for patients, with cancer. You can see here, again, there's 1 to 2 log orders difference in septic shock and 2 to 3 log order differences in cytokine storm. And this is where tocilizumab and other interleukin 6 antagonists are used. So it's appropriate here where you have very, very high levels. Is it necessarily appropriate in COVID where the levels are much lower? And in fact, that's what the multi-center trials that are now coming out are showing. So Sanofi abandoned their trial on Kevzara, or sarilumab, which is an interleukin 6 antagonist, 194 ventilated patients, no difference in outcomes. And recently, Roche put out a press release on tocilizumab, a phase 3 Covacta trial, also placebo-controlled, double-blind, randomized, and again, didn't meet its endpoint of improving outcomes in patients or reducing mortality. So the question is, if it's not a cytokine storm, is COVID-19 actually hyperinflammatory? I think the answer is yes. However, we don't necessarily need to relate it to lots of cytokines. Certainly, there's a very big acute phase response. Lots of studies have shown CRP, ferritin, serum amyloid A, complement, fibrinogen, etc. are elevated. Other acute phase reactants haven't, to my knowledge, been measured. But certainly there is a very profound acute phase response. And just as an example, we've been looking at patients we admitted to the unit on CPAP who either did well or needed to either be intubated subsequently or died with CPAP as the ceiling of care. And I've compared this against a paper that came out a number of years ago in Chest in ARDS, so equivalent populations, but you can see the CRP levels overall were around 200, 250 in the COVID population we had, whereas in the ARDS population, they were lower, averaging around 150. So I think there is a hyperinflammatory response, which, at least in terms of the acute phase response, is more profound. In summary, I think we're talking much more about cytokine breeze rather than a storm for COVID-19. And I think this misunderstanding has driven a lot of futile treatments to be given to patients, some of which carry potential harm, and a load of futile studies. I think an interesting question is, what does drive inflammation in COVID-19 if it's not cytokines? And I think, again, highlighting the fact we need to know a lot more. On that note, I'll finish. Thank you very much indeed for listening.